He will not force
Well, thank you for the opportunity of giving this talk. I mean, it should be called a half-term talk. Anyway, it was an opportunity really because the bariatric unit in Oxford is now 6 years old. First case done in 2008. 8 years old, and has been, as always, a kind of a small unit compared to big bariatric unit, and the small unit attached to the upper GI service that is a big cancer unit, and so has been kind of bringing particular challenges, but also opportunity, because obviously complications of bariatric surgery are, yes, unique to bariatric surgery, but the general principle of dealing with complication is really the same as upper GI complication, and you know, probably you all know how complicated can be upper GI complications with sepsis and all the rest, and obviously if things go wrong, you ended up removing part of the upper GI tract also for bariatric surgery, and pure bariatric surgeon actually don't do any major resection. So, I mean, people say, oh, bariatric surgery should only be done by bariatric surgeons. I think that actually the complication after bariatric surgery can be dealt probably even better off by an upper GI surgeon. But anyway, the new challenges don't come from a clinical point of view, in my opinion, because the patients are out there and are pretty much the same. We know what they are like, and we know what their complications are like. That hasn't changed at all. So this is kind of my starting point. I mean, we can look at things and challenge ourselves with robotic surgery, laparoscopic, endoluminal drugs, etc., but the problem, it remains the same, and it's because the population is growing in size, and certainly the complications are not going to get any better. So I think that the challenge for the future is the fact that we end up having a tunnel vision so easily. That's so common and, you know, and well known for laparoscopic surgeons who forget about what's in the rest of the abdomen and just focus on the center of the screen. But at the same time happens to the commissioners when we think about deciding a budget to dedicate to bariatric surgery or the complex obesity pathway or the chronic illness disease. The patients who obviously have got their own opinion about what bariatric surgery is, the bariatric team that, you know, often surgeons are certainly enthusiastic about a new treatment and bigger operations, and the society that, I don't know, probably doesn't pay much attention to the obese population. So the commissioner perspective, in my opinion, is the vision is pretty easy because it's based on statistical data, and the way that this is analyzed that's the problem, because I'm not sure that all these bodies kind of talk to each other as they should. But this is what they base their analysis from, and it's pretty clear. I mean, this is up to 2006, with 24% of the population being obese. That data is going to almost reach 50% by 2050, and it's for both male and females. And it's a big and expensive, this problem, the one that they have to address, because the prevalence is increasing, the incidence is increasing. The 5% of the total NHS budget is invested, let's say, in obesity and its complication. 2.3 billion were directly utilized for obesity treatment, and dealing with the complication that comes from obesity, as you can imagine, as you all know, actually, it's just huge. So the Commissioner's response to this problem has been to utilize the NICE guidelines that regulate bariatric surgery, or let's say obesity, complex obesity in general, and produce this complex obesity pathway. The complex obesity pathway, it's good. Let's say it is useful at least. And as you can see, it starts down into public health campaign, reinforce healthy eating. That just doesn't work. And it's paid by local authorities. They've got little budget. Then patients move up to Tier 2, that is a lifestyle weight management service. Again, it's community-based, rarely led by a GP, and consists in lifestyle intervention. A group of people with weight problems walk into a room and they are just told, oh, you have to exercise more or you have to eat less. And funded by local authority, little money, and doesn't work. And the patient's BMI goes up and up until they are referred to Tier 3. Tier 3 is a very debatable entity that is not always present in UK. Actually has been sponsored by John Was, professor here in Oxford, and has been a very important kind of a person for the bariatric surgical community in the UK, as it did analyze and kind of set down the criteria for bariatric units. This Tier 3 is clinician-led, has got an MDT in place, and sometimes the physician is a GP with a special interest in obesity, and there is a psychologist, there is a dietitian, and also specialist nurse. This is a very important tier, in my opinion, because with regards to the population of patients who end up having bariatric surgery, is a mandatory group. They have to go through this, almost everyone. And it's funded by the CCG. That's a big difference as well. And then Tier 4, bariatric surgery, that is based in the hospital, now paid by the CCGs. The procedures are paid by the CCGs, whilst up to a year ago it was NHS England. And obviously MDT and the full-blown preoperative assessment, preparation with psychologist, dietitian, specialist nurse, the surgical assessment. Here is where we send lots of patients for further specialist assessments, such as cardiac investigation, endoscopies, respiratory assessment, especially to rule out obstructive sleep apnea. It is an expensive tier, bariatric surgery. Quite a few patients from our unit end up having a specialist assessment before an operation. But this is what has happened in the last few years. Instead of increasing the numbers of bariatric procedures carried out per year, it's actually in 2014 there has been a big drop. And that's because this complex obesity pathway, it just doesn't work as a nice stepwise process. It's a hurdle race, in my opinion, and there are criteria such as a minimum of 24 to 12 months in Tier 3, down to 6 months for the patient with a BMI of over 50. Hopefully 2015 and 16 will show an increase in number. This drop in numbers of procedure reflects also the fact that most CCGs were not prepared with a Tier 3, so had to be set up from scratch. The society perspective on obesity is quite depressing, in my opinion. I mean, I see lots and lots of obese patients, and they've got horrible stories behind, and you just see how there is not dedicated support in a way. There is no understanding of what they are like, what their past is like. So the society is obesogenic for various reasons. Discrimination is a major problem. I believe I still run the only teaching at the uni in Oxford on obesity. It's supposed to be, it's called bariatric surgery teaching, but I literally dedicate 3 minutes on bariatric surgery procedures. I just spend all the time going through how a patient can reach a BMI of 50 without being to be blamed, you know, as we all do when we see a big patient a big individual on the street. Globalization of markets, media, education that is totally lacking, and when it's present, is dedicated, is in a way is a non-effective delivered in a non-effective way. Access to food, fast food near the school, the fast food near in the deprived area of Oxford is quite shocking. Political choice, and obviously an environment that doesn't encourage any physical activity. And this is what is being done at that level. We'll cut this. But really, not even the tax, the sugar tax in place. I mean, it's quite shocking. Then we get into the more interesting bit. Because let's say that 8 years ago, 6 years ago, I used to look at the patients on the left as literally a target for surgery, and this has been been the major change in my personal practice. But the patient, when they think about bariatric surgery, they've just got one thing in mind, and that's how they're going to end up after that experience. And certainly they would like to end up slim and fit, and more importantly, and even more difficult, happy. They would like their life back. They would like a new start. They want an opportunity to be happy again if they have ever been happy. But this is what they really don't know, and what I know. And forgive me for this is for patients from the American Society of Metabolic and Bariatric Surgery, but I don't think that there is any other diagram around that kind of brings together all the goods of bariatric surgery. Almost a complete resolution of obstructive sleep apnea, asthma, a reduction significant in the cardiovascular disease, hypertension. A gastric bypass is the perfect treatment for acid reflux. Urinary stress incontinence, that for ladies represent one of the elements that affects the quality of life more seriously. Degenerative joint disease. Arthroscopy don't work. The only thing proved to improve knee pain is weight loss. Gout, a reduction at 5 years in the overall mortality. And there is an interesting study showing that especially is the mortality related to cancer, the one that is reduced. Improved quality of life. Jeremy, this will put all the varicose vein off, but as you can imagine, the lymphedema and the lipoedema in these patients is quite often a problem, especially because it limits the mobility, and by limiting the mobility, limits the ability of burning calories, and the bariatric surgery is very effective in improving that. PCOS for ladies, it's just unbelievable. A bypass done in a young woman with irregular or no menstrual period will have their periods within a week of the operation. It's almost 100%. It's unbelievable. Type 2 diabetes, up to remission in 83% of the patients. So it depends on the type 2 diabetes. They are not all the same, but, and as a consequence, improvement in metabolic syndrome. It can even improve the fibrosis induced by fatty liver. And obviously, it's very effective in the steatohepatitis, dyslipidemia, and other problems. But overall, I don't promise that their depression will go away. And in fact, it's only 55% improvement. And that used to be my my view, yes, the bigger the patient, the bigger the challenge, and it was more surgical, attitudes. But now we know that both the patients and myself, we are more looking like this after surgery, and the search for the perfect patient and the patient search for the perfect treatment to improve or resolve all their problem is more like looking for the holy grail. And during the MDT, I keep asking the psychologist, what is it that you're going to tell me after you see this patient? That he's not perfect, that he will struggle to adapt to the changes? And because this is, I would say, probably 95% of the patients. Absolute contraindication, this is what I keep asking the psychologist. What are the absolute contraindications for bariatric surgery? Because some time ago we thought that people with eating disorder were absolutely a no-go. Now we know that is not the case. So I think that at the moment, but still things can change, the two absolute contraindications are psychological, let's say, and are the presence of an active psychotic behavior and the depression with active suicidal thoughts. Obviously, there will be kind of MDT process behind an operation that will stop a patient's surgery, but I would say there probably is a small group of patients who are, let's say, whose comorbidity or end-stage organ is at such point that there will be not a chance of improving it. Yeah? So in those patients, I would say no. And this is the reason why we end up sometimes stuck after surgery with progress, let's say, is a complex background because of family work and overall the environment, the society. It's just not helpful. And if someone gets to a BMI of 50 or so, there are deep problems in their overall life, and are quite difficult to. They don't come out. They don't come out. Psychological issues are pretty much always there, but this 60% of the patient with BMI over 50 have got major problem, and those major problems are often because of abuse that have been victim of during their childhood, and usually is a sexual abuse, and usually is from a member of the family. So whenever I sit, and this is what I tell the medical student, whenever I sit in front of a patient, I know that there will be things not coming out, and that's why I'm no longer judgmental on why they ended up at that stage. We don't know what's behind that the stories of these patients. And the other reason is because the obesity-related comorbidities are so many, and 15% of the patients I operate on have got an end-stage organ. So one of the, I received so many referrals from the respiratory team because of severe obstructive sleep apnea that is often mixed with COPD, and the renal team. I'm pretty sure that it would be the #1 referral group if they had, so many patients, probably, I would say. But I've operated in people with end-stage renal failure, pre-dialysis. And the reason is because bariatric surgery still represents an extremely effective treatment in stopping the progression of those diseases, and sometimes even improving the organ failure. But as we have recently seen in a patient, there are limitations on that. So sometimes that liver, those kidneys will not recover. And hence the extremely good relation that we have established with the other specialist team. And on an average, the patient I operate on have got 7 comorbidities. For the patients, the thing is even more complicated because there can be body image issues. There is, just last week I saw a lady told me that 6 months after surgery, she saw herself in a mirror in a supermarket, and she waved at her reflected image. She didn't recognize herself in a mirror, and that could be good from some point of view, but also it can lead to quite major problem, and not all of them are able to cope with this. The change in the relation of the food with the food, it's quite important, especially at the beginning, and that is usually caused by a degree of restriction, and the fact that food as an emotional support is no longer so easily available. The interaction that we have around food, it's quite important as well, and that for patients will change. From more kind of medical point of view, there is a degree of patient who will end up with abdominal pain, and these patients with abdominal pain are particularly tricky because they will undergo a number of investigations from endoscopies, barium mills and follow-through, CTs, eventually laparoscopies, and the cause of this pain is not that easily found. So there is 1% of the patient who will be left with severe abdominal pain, not responsive to treatment, and without knowing why. As you can imagine, they will end up being on morphine and other type of drugs with severe side effects. Food intolerance, after a gastric bypass especially, their response to fruit and vegetables, 5 a day, the healthy diet, it will be a bit of a problem because that will increase the amount of gas in their bowel, as these nutrients will be only partially digested and will end up in the colon causing lots of gas, and that's a problem. Food choice, we do tell them that they will be able to eat everything, but there is a variability, and certainly we have seen patients who struggle with bread, others would struggle with eating dry kind of food, chicken and stuff like that. And there is a degree of unpredictability on that. Some type of food tends to clump together, rice, couscous, sometimes pasta. So it's very difficult to tell a patient to predict exactly what's going to be their life before surgery. And food preference. Bariatric surgery works at neurohormonal level as well as in kind of gut hormones, and that will completely change their food preference. People will come off sweet, or they will become more kind of prefer sweet after surgery, and that again there will be a lot to adapt to, leading to results that is suboptimal, but even then suboptimal probably means it was simply so difficult to predict the outcome, to give the patient a realistic expectation, that the patients end up being a bit unsure about their position, their overall quality of life. As a patient, have I made really this progress, and is my quality of life really better now? The environment, as I said yesterday, will be extremely judgmental, either for the big people or as for the big people who no longer eat as used to. There will be lots of questions. There will be lots of attitudes towards these patients after surgery that are not so easy to manage. People ask about, what's wrong with you? Why you're not eating? Or especially for men, why they're no longer drinking 5 pints of beer on a Friday night. So these are all things that over the last 8 years have in a way puzzled me and make me think, what is it that we are really promising these patients? And then they get angry. And rarely they get angry at the medical team because they become a bit dependent on us. They get angry at themselves and people who surround them. And as a consequence, the risk of weight regain, it's certainly there. Now, weight regain is, I'm probably drawing a pessimistic view, but it's just my reflection, really. The weight regain is not that common, and bariatric surgery is by far the most effective treatment for obesity, and also the only one that is able to produce long-lasting results. And now we've got studies from Sweden showing positive results at 25 years. After a gastric bypass. And with the sleeve gastrectomy, that is the operation that I now perform certainly more often, at 15 years. So I'm not challenging what I do at all. I'm just putting here my reflection, really. It's just a matter of saying, what is it? How has my practice changed? And why? So the new challenge is is to look at the complex obesity as a steep, long hill. And it's going to be hard to win, and probably we will never win. But we have to look at these all together, from commissioners, patients. I would love to say the society, but that is not going to change, I'm afraid. And obviously the bariatric team, with our effort in preparing patients before surgery as well as we can. And it's certainly a team group. And this picture, I was recently into this cycling event in Rome, and when I saw this picture, I felt almost ashamed of myself, because actually the guy behind me kind of pulled me for the last 30K of the race. I was so tired. It's totally a team effort, but the effort in addressing the complex obesity in the society. So the relation between commission and society, that's probably it's the most difficult to address, really, I think, because there is a lot to do, but we have known about these things for 20 years, and I'm not saying that in other parts of the world there are people that have been more successful experience, because it's pretty much the same rubbish outcome, I have to say. The commission and the bariatric team, this is the most interesting bit. I have to say that I'm very much a clinician. I love operating, and I'm not that good at policy making and discussing with commissioners. But but in the last 2 years, we have had very, very encouraging meetings with the CCGs, and there has been changes. So what we have tried to make in Oxford is to change the complex obesity pathway, so that it no longer looks like a harder race for patients. It's not the design of the complex obesity pathway. It shouldn't be to put barriers towards surgery to save money. And so we have focused on the patient who really would need, patient who will never, let's say, succeed without surgery, and the one that are more likely to die because of obesity. And on the mortality rate for the obese is quite shocking, because a man of 50 years of age with a BMI over 50 and diabetes has got literally a 50% survival at 5 years if untreated. I like talking about kind of cancer results to the medical students, because the comparison with some cancers is actually quite dramatic. Colorectal cancer stage 3 has got a 60% survival rate at 5 years. Here we are talking of totally benign conditions, and actually it's got a worse prognosis in a way. So with the commissioner, we are trying to identify these patients early. There is no point in putting that big patients with lots of metabolic comorbidities through a 2-year program. That is not going to work. It's not going to work. If you are on insulin, if you have got poor mobility, the chances of losing weight are good, but the chance of maintaining the weight loss achieved during the first 6 months, it's virtually zero. So instead of investing all the limited resources in patients who are actually not a high risk of serious complication because of obesity, we are trying and dedicate most of the resources to the sicker patients and the one that will benefit the most. And if you think about 1 year in hemodialysis, it costs £55,000. So even if we are able to delay one patient from ending up in dialysis, we will have saved £55,000. And with £55,000, we will be able to operate on 7 patients now. So the cost saving and the distribution of the changes in the distribution of the resource that could be done, it's quite amazing. And there will be huge clinical and cost improvements. We are also trying to move our presence down on that complex obesity pathway. If we are kind of up there waiting for tier 3 and GP to refer patient, we will only see the worst, or let's say the worst candidate, let's say, the one that will have less extensive improvements after bariatric surgery. Because if you operate on the elderly or on the patients whose diabetes is older, for example, the results will not as good as if you operate on young people who are on metformin only, for example. So we have start moving our presence down to tier 3, and maybe if we have recently managed to appoint an extra CNS and dietitian. So hopefully our presence will also be in lower tiers, maybe tier 2, and we'll be able to visit more GPs. Because I really believe that is the patient selection it makes everything. And we are trying to improve the support that we can offer to patients from, yes, psychological, but I think that, again, the psychological point of view, I think the aim is just to identify those patients who are likely to kill themselves after surgery, or the one who will get completely lost at follow-up or completely out of hands with the outcome. It's more the trying to educate them and their families in supporting them in the short term, where the changes after surgery will be certainly more important, and in the long term, so that the weight loss maintenance will be as effective as it can be. And and the weight loss maintenance program is tier 3, where we try and work very closely together. We have tried to dedicate one of our MDT for tier 3 patients, so that they can directly refer these patients to us. And streamlining high-risk patient, the CCG has been responsive on this, and the individual funding requests have, in a way, are less complicated than they used to be up to 2 years ago. So if we really have a case that we consider special and deserving funding quite quickly, and recently we have tried to use these for a patient with a brain tumor, and to try with a BMI, was 185 kilograms. I don't remember the BMI, and there was. And the operation had to be done in a prone position. So the neurosurgical team kind of asked us, what do you think? Can this be done, in a staged manner? Can you do bariatric surgery first, so that we can then operate on the brain tumor with reduce perioperative comorbidities? Yes, I thought that was a very good indication. Unfortunately, things didn't work out because of the brain tumor itself, but that was, this is the way the CCG has been responsive and has been listening at. We've used this kind of stage approach for a few cases so far, colorectal cancer and also an adrenal cancer. Both have been very successful. So what is it that we ask the patient? And it's a preoperative commitment. They really have to show their commitment to this bariatric surgical process. That is not easy at all. I hope I have passed the message that it's a very difficult surgical specialties compared to cancer surgery or even more, other specialties. And patients really have to prove commitments and show that he's able to make changes, improve mobility. There is plenty of evidence now that wearing a Fitbit, one of these wearable technology things, can improve outcome. It will give the patients a better idea, a better understanding of what their mobility is like and what maybe it should be. We have a zero policy for smokers. We are simply not going to do surgery, especially because it leads to a much higher risk of post-surgical complication, not just respiratory, but also anastomotic ulcer and bleeding from the upper GI tract. Alcohol, we have got a zero policy for zero tolerance for people who abuse of alcohol. And interestingly, alcohol will, after surgery, will be a different experience in the sense that they will get tipsy earlier. They will have no hangover symptoms, but more worryingly, the alcohol level in their blood will be higher for longer. So literally after surgery, if they have drunk too much at night and they drive in the morning, they can still have a positive reading for alcohol. So, and this they have to be educated properly about that. And then weight loss, thinking about what is it the weight loss they expect to achieve. So again, it all goes back to managing expectations. And we are also dedicating quite a lot of our resources to patients in trouble throughout their experience with us. At the moment is 2 years, so we follow them up for 2 years, but I would like to extend this follow-up to 5 years. So quite a lot of resources are invested into this rescue program. We'd rather see the patient at the beginning of any weight regain rather than after they have regained 30 kilograms. And as you can imagine, that is, we ended up seeing these patients early or late based on how good our relation is. If they don't feel like they're going to be, we are judgmental and so on, it's more likely that they will come back early. And the emergency backup. This is another problem because although the number of bariatric procedures that has been carried out in UK is not huge compared to other European countries, and there has been a slight drop in the number of procedures, there are still thousands of patients who have had bariatric surgery, either NHS, privately, or especially abroad. And they will present with serious emergencies, especially those with a gastric bypass. So to try and optimize patients towards surgery, we run a bariatric assessment that, again, if you see our bariatric pro forma for the assessment from 2008 when we first started it, to what it is now has completely changed, and has changed mainly because of complications, but also has changed because of need of emphasizing, looking more at different things that with experience just became obvious. So the weight loss history of a patient is important because there will be quite all of them will say, oh yes, I'm always able to lose weight, but is the weight regain that is the standard. So we try and spend a little bit of time to try and understand how quickly that regain happened, and to try and understand why, what kind of diets they follow, what kind of diets they were more successful, because we can then direct our advice afterwards towards different types of diet. I've told you about the psychological assessment and screening. All the patients are screened from a psychological point of view. And the assessment of the comorbidities has completely changed, I would say, probably in the last 4 years. And now, from a renal point of view, we've got far more patients with CKD, patients with well-established cirrhosis, cardiac issues, and diabetes, and especially thanks to the liver side and the cardiac side, and a bit to the diabetes. In the last 6 years, we've been able to support 4 PhD students, and now there is a 5th one with a very ambitious program. So the bariatric unit is kind of also slowly making progress towards being recognized from an academic point of view. The education for these patients is very focused on what's going to be life afterwards. I don't need to convince them about how safe these operations are, because they are extremely safe. And I have totally stopped asking the patients, what operation would you like? Because they don't have enough knowledge and understanding of their own situation to come out with a useful opinion about that. And years ago, the first thing is still in our pro forma, patient's choice for surgery. I mean, that was really I think was really wrong, and was all because of, in part, the gastric band that was sold as an effective, very effective tool all the time. So we have literally stopped doing gastric bands. We only revised gastric bands to other procedures. So patient choice is totally gone. And the education is now also delivered by other patients. So we have a support group that is totally run by patients, and nobody, another patient who has undergone the same operation will be able to tell and explain what life is going to be like, and that is so valuable. All the patients must attend that. So I think I'm reached my conclusion, and sorry if this talk wasn't very kind of clinical or scientifically supported, but it really are my reflection after years of bariatric surgery. So on the broad picture, I think the bariatric surgery certainly shouldn't be stopped, but actually should be even more supported. But we shouldn't look at the fixed number of operations to be done. I think we should look at the population and identify the efforts should be directed in identifying the patient who would benefit the most. Because only in Oxford there would be 8,000 patients who would qualify for bariatric surgery according to the NICE guidelines. In the whole of the UK it would be 4 million today. They just don't knock at our door because they are unaware of this option. So it's impossible, to say, oh yeah, we should do more bariatric operation, we should operate on all the one that qualify according to NICE guidelines. No, I'm certainly not saying that. I think we should really put our effort in identify the one who will benefit the most and prepare them as well as possible so that after surgery we will avoid disasters from a psychological point of view and also from a metabolic point of view. Because if a patient is not well educated and doesn't understand the importance of being on a correct diet with an adequate protein supplementation and multivitamins for life, certainly will end up in a worse situation than before surgery, with spontaneous bone fracture, progression of their obesity-related comorbidities, and simply will not do well. And again, delivering a realistic outcome. That was my last slide. Thank you.